This meeting is starting an hour earlier than our normal time in order to allow the executive director and me to attend at 2 o'clock the annual meeting between the state, HSCRC, the department, us, and CMMI. Given that this is a remote-only meeting, additional ground rules will apply. I'll begin the meeting with a roll call of commissioners. During the meeting, I'll ask the people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's talking and will have the same knowledge as if we were all together in room 100. We're using the Zoom meeting platform today. All commissioners are unmuted and may speak, or all commissioners may unmute and speak. I ask them to remain muted at other times so we limit the background noise that comes in. The public and most staff should self-mute and may not speak unless recognized by me. Due to the possibility of background noise, I ask that all others remain muted when not speaking. For this meeting and at future remote-only meetings, we'll post documents that'll be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I will now call the roll. Commissioner Akintate.
Here, sir.
Commissioner Bandari.
Here.
Commissioner Boyer.
Here.
Commissioner Boyle.
Here.
Commissioner Brumbutt. Don't believe I saw her before.
He should be on shortly. I just sent him the registration link again.
Okay, sure. Commissioner Cheatham.
Here.
Commissioner Dordan.
Here.
Commissioner Jensen.
Here, sir.
Commissioner Metz.
Yes, sir.
Commissioner O'Connor. Don't think I saw Dr. O'Connor before. Okay. Commissioner O'Grady.
Here.
Commissioner Reimer.
Here.
Commissioner Sargent. I believe he was going to be a little bit
Very
late.
good. Sorry, nope, I was fumbling with mute. I'm here.
There you go. All right. And Commissioner Wang, I saw.
Here.
Outstanding. All right. Any other commissioners joined the call? All righty. So at this point, I'd like to introduce Commissioner Jensen. Governor Hogan has appointed Mr. Mark Jensen, a senior partner at the law firm of Bowie Jensen, to replace Dr. Thomas beginning this month. Dr. Jensen is being asked to assume the seat that was previously held by Dr. Thomas. We don't ask anybody to replace Dr. Thomas necessarily. Mark has held leadership positions with multiple community organizations, MedStar and the Maryland Hospital Association for the past 2 decades. I'm most impressed with Mark's commitment to community-based organizations and his compelling personal story to assist those in need. I believe he'll bring his experience and insights in public service and health systems to the commission, and we welcome him. Commissioner Jensen, welcome.
Thank you, sir. I just very briefly, I appreciate this opportunity after over 20 years in hospital governance and then hospital policy and advocacy, all focused on patient safety and quality. I appreciate I'm interested in the opportunity to take a look at those issues from the regulator's perspective. So thank you.
Thank you. All right, on to agenda item number 1. Before we go, I'd like to remind staff and everybody that we are trying to maintain a tight timeline today. So if comments could be succinct and to the point, I appreciate it. Certainly if there are items that we need to discuss, we will discuss them. But hopefully we'll be able to get through this expeditiously and get on to the next meeting. So agenda item number 1 is approval of the minutes. Included in your packets are copies of the minutes from the September 23, 2021 public meeting of the commission that took place in person and by video conference. I'll entertain a motion to approve the minutes of the September 23, 2021 commission meeting. Is there a motion?
I so move.
That was Commissioner Akintate, and I think I saw a second from Commissioner Boyle. Any comments, questions? All in favor?
Aye. Aye.
Aye. Aye.
Aye.
Any opposed or abstain? Very good.
Hey,
Agenda,
Dr. Pollock, Dr. O'Connor, I just tuned in.
welcome. Thank you. All right, agenda item number 2 is update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Hearing none, does the executive director have any updates?
Thank you, Dr. Pollack. Recognizing your directive, I'm not going to give my usual update. I did provide some information via email this morning. On behalf of the staff, I wanted to recognize and welcome Mr. Jensen to the Healthcare Commission. That's all I have. If you do have questions on the update, an option, as always, is to email me directly, and I'll answer or direct them to appropriate staff.
I believe,
Chairman,
go ahead.
Yes, I apologize.
Commissioner Matt.
On Ben's written update, I'd like to make one disclosure. I was formerly affiliated with Hearthstone Nursing and Rehabilitation Center, which is listed as a pending sale. I am not affiliated with that company or any of its affiliates at this point.
Thank you.
Thank you.
I believe Ken has an update. Is that correct? Ken Yates?
That's correct.
Give an update on the expansion of the Where the Cost website. We're going to see added interest in this website as the episode definition software used by Where the Cost is very similar to the episode definition software that's going to be used in the EQIP program, the Episode Quality Improvement Program, which is a new HSCRC care transformation program that will launch formally in January 2022. HSCRC now reports that 7,400 physicians and other healthcare practitioners have applied to participate in that program. CMS will accredit the providers to participate in November next month. I hope at some point in the near future that we'll have an opportunity for the HSCRC to provide a brief introduction to that program to the commissioners. Ken?
Thank you very much, Dr. Pollack. Good afternoon, commissioners. The commission has released new commercial data using the 2018 and 2019 data from the MCDB for 10 existing episodes and 3 new ones for a total of 13 episodes at hospitals across the state. The 3 new episodes are coronary angioplasty, knee arthroscopy, and tonsillectomy. That's my update.
Thank you, Ken. More to follow on that, obviously. Courtney Carter has an update on Maryland Hospital's performance on the quality measures during the COVID pandemic. Courtney?
Thank you, Chairman Pollack. So the Maryland Healthcare Commission publicly reports healthcare-associated infections in hospitals annually on the Maryland Quality Reporting Consumer website. And prior to 2020, when the coronavirus pandemic hit, Maryland hospitals had made considerable improvements in infections over the years. So recently, the Journal of Infection Control and Hospital Epidemiology published an article comparing each quarter of national infection results from 2020 to the respective quarter in 2019 to assess the impact of COVID-19 on incidence of healthcare-associated infections. National results showed quite a bit of variation. There were actually significant improvements in infection rates in the first quarter of 2020 for most infection types. And performance was also better for surgical site infections and C. diff in 2020 compared to 2019. However, in the later quarters of 2020, infection ratios did increase significantly for central line associated bloodstream infections, catheter associated urinary tract infections, and MRSA. Staff replicated the methodology from that study, and we used data from CDC's National Healthcare Safety Network to compare statewide results with the national results. We found that the state did not see such a wide variation in results like the nation did. Maryland hospital performance was, for the most part, steady. We did see increases for most infection types, but the increases were only statistically significant for central line associated bloodstream infections and catheter associated urinary tract infections, which was similar to the national results. Reporting for these type of device-associated infections is location-based within the hospital, and it does include ICUs, which we know were heavily utilized in 2020. So these results really aren't too surprising. However, even though we did see significantly higher infection ratios The results still did fall within a normal or expected range. So this shows that in a time of crisis and unprecedented challenges, Maryland hospital performance on infection measures was relatively stable. Preliminary analysis of 2021 data shows that for most infection types, the numbers are starting to slowly go down, and we do expect that to continue. However, we know the pandemic isn't over, so it may take some time to get back to where we were as a state in 2019. MHCC will keep monitoring performance and will report back next year when we have a full calendar year of 2021 data. And that concludes my update. Thank you.
Thank you, Courtney. I'll just add that I think that, from a ground level provider perspective, the challenge right now is not the pandemic. It's the staffing issues that we're facing that are peripherally pandemic related. But the staffing crisis that Maryland hospitals are facing right now is unlike anything that I've seen in the past, and it is clearly impacting patient care. So,
Mr. Chairman,
yes.
Commissioner Jensen here, just very, very quickly. In that study, I think we were comparing national rates with state rates. I'm just wondering if there was any breakdown in regions in the state and if there was any big disparities in those regions.
Courtney, do you have any information on that?
No, we did not break it down to that level, but if that's something that you're interested in, we can follow up with that.
Thanks. And Commissioner Jensen, you're certainly free to reach out to staff directly on those issues afterwards for more information as you would like.
Thank you.
Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform me. For commissioners participating remotely who wish to recuse, they should remain silent, turn off their cameras and mute their phones. And I believe all the commissioners who are participating remotely right now. So on to our action items. The agenda item number 3, the CON for Avenues Recovery Center of Chesapeake Bay to establish an alcohol and drug abuse treatment intermediate care facility. Avenues Recovery Center of Chesapeake Bay proposes to establish a 20-bed Track 1 intermediate care facility that provides American Society of Addiction Medicine level 3.7 and 3.7 withdrawal management services for adults in an existing 104-bed center substance use disorder facility located in Cambridge. Program manager and CON analyst Bill Chan will present the staff recommendation. Bill, please proceed.
Thank you, Chairman Pollock, and good afternoon, commissioners. Avenues Recovery Center of Chesapeake Bay proposes to establish a 20-bed Track 1 intermediate care facility for adults in an existing alcohol and drug abuse treatment center in Cambridge. This existing center currently operates as a 104-bed center for the treatment of substance use disorders, offering a continuum of care from outpatient care to residential treatment. The proposed project will allow this center to provide a higher level of care, the medically monitored intensive inpatient care of the ICF for withdrawal management and subsequent inpatient treatment. A Track 1 ICF, as defined in the state health plan, is an ICF in which the majority of the patients served to rely on private insurance or their own resources to pay for services. It's important to note that this proposed ICF does not fit this description based on its payer source projections. Avenues is owned by the Livorno Trust, Yehuda Alter, and Joseph Cohen. It operates 8 other substance use disorder facilities across the country, including the Avenues Recovery Centers in Cambridge and in Prince Frederick in Southern Maryland. It also operates facilities in Pennsylvania, Louisiana, Indiana, and New Hampshire. The total estimated cost for the proposed project is $55,000 and is limited to non-construction expenses. Space will be used for the ICF already exists in an appropriate configuration, and the entire center was remodeled prior to opening in the fall of 2020. Space was formerly used to provide psychiatric hospital and residential treatment center services. The applicant will fund the project with cash. Could I ask for slide number 1? Thank you. Current city health plan standards for ICFs include a methodology for projecting the need for Track 1 ICF beds. As can be seen in this slide, employing this need standard would not support the addition of ICF beds on the Eastern Shore. However, staff recommends that the commission find this need standard to be inapplicable because of a change in the scope of CON regulation that was supported by MHCC and went into effect in 2019. Prior to 2019, MHCC regulated all additions of ICF beds in the state through establishment of new ICFs or expansion of existing ones. This scope of regulation is consistent with the use of a bed need projection standard. However, under the law changes, existing ICFs can add any number of ICF beds without CON approval. This change in the law allowed a large number of ICF beds to be added to the bed inventory of the Eastern Shore without any need for approval by MHCC. And just to illustrate, this slide here shows on the first green line that is the inventory of ICF Track 1 beds on the Eastern Shore as of 2019. There were 3 Track 1 facilities, 46 beds. The second green line illustrates after the change in legislation in 2019, the inventory increased to 148, and it shows from the first line to the second, the change in the need for the Eastern Shore for ICF beds. So as I continue, it is also important, as I noted earlier, that the applicant is proposing service to a large proportion of low-income patients whose care will be supported by public funding sources, primarily Medicaid. This type of operation would more accurately be described as a Track 2 ICF operation, but is not subject to the state health plan's bed need projection. Avenues believes that its proposed ICF will serve patients residing throughout the state of Maryland and beyond the state's borders, based on experience in Maryland. The applicant also makes the case that Medicaid enrollees are a medically underserved population on the Eastern Shore. With only 35 ICF beds from 2 existing ICF providers participating in this program, about 20% of the total ICF bed inventory on the Eastern Shore. Staff feels that the need for this project has been adequately demonstrated. Staff has calculated that the project will improve the availability and access to ICF services for all classes of patients and will not have an appreciable impact on costs or charges for substance use disorder treatments or existing ICFs. Staff also believes that the applicant has demonstrated that the project can be funded and that the ICF operation is likely to be a viable operation. But I now have slide 2. Thank you. For these reasons, staff recommends approval of the Avenues project. Staff recommends that if the commission approves the CON for this project, it includes the following conditions, which are standard conditions that staff recommends commission should issue to applicants seeking a new ICF, reflecting specific requirements of the state health plan addressing service to low-income persons, accreditation, and the development of appropriate relationships with other facilities and programs for referral of patients and for continuing care of patients following discharge from the ICF. And could I just also have you talk about your slide 3 as well, since these are the 5 conditions. Have slide 3. Thank you. Before I move on to questions, I would like to introduce several representatives of Avenues who are present at this meeting. These include Yehuda Alter, an owner, Jamie Schleicher, Director of Regulatory Compliance for Avenues, Carolyn Jacobs, Counsel, and Andy Solberg, Consultant. And with that, I conclude my presentation.
Thank you, Bill. Do I have a motion to approve the CON for Avenues Recovery Center at Chesapeake Bay to establish an alcohol and drug abuse treatment intermediate care facility? Commissioner Bandari, do I have a second?
Second, O'Grady.
Second, O'Grady. Great. All right. Comments, questions, commissioners? I think you've done a nice job of presenting this, and I don't think I don't see any questions. I don't have any questions. All in favor?
Aye.
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 Any opposed or abstaining? All right. Congratulations. The Avenues Recovery Center of Chesapeake Bay to establish an alcohol and drug abuse treatment intermediate care facility is hereby approved. All right. Moving on, action item number 4, exemption from certificate of need review the conversion of Grace Medical Center to a freestanding medical facility. Sinai Hospital of Baltimore, Inc. and Grace Medical Center, Inc. as co-applicants seek an exemption from CON to convert Grace to a freestanding medical facility, or FMF. The FMF will be located at on the existing Grace site, or the former Bon Secours site, for those who recall. Program Manager and CON Analyst Eric Baker will present the staff recommendation. Eric, please proceed.
Good afternoon, Chairman Pollack and Commissioners. This request for an exemption for CON is for the conversion of Grace Medical Center in West Baltimore City to a freestanding medical facility, or FMF. An FMF is an emergency center affiliated with the General Hospital that operates 24 hours per day, 7 days per week, under the medical direction of a board-certified emergency physician. Its emergency services and patient observation services, if provided, are rate regulated by the Health Services Cost Review Commission. An FMF campus may include other types of outpatient care, and these may be rate regulated at the discretion of HSCRC. Legislation passed in 2016 authorized conversion of general hospitals to FMFs with the approval of MHCC through an exemption from the CON review process. An exemption can be issued based on review of the project under 4 criteria. Maintenance of adequate and appropriate delivery of emergency care within the statewide emergency medical services system, as determined by the State Emergency Medical Services Board. Consistency with the state health plan, improvements in the efficient and effective delivery of healthcare services, and a finding that the project is in the public interest. Applicants in this request are 2 general hospitals operated by LifeBridge Health System Incorporated. First, Grace Medical Center Incorporated, which operated for over 100 years as Bon Secours Hospital in West Baltimore, which is an area of the city that includes a substantial number of low-income and minority neighborhoods. Historically, this hospital has played a major role in providing availability and accessibility to general hospital services for this very vulnerable part of the city. It was acquired by LifeBridge in 2019. Sinai Hospital of Baltimore is one of the largest community hospitals in Maryland, and it will serve as the parent hospital of the proposed FMF. The transition of this small hospital campus began in 2019 after the LifeBridge acquisition. In that year, MHCC authorized additions to the psychiatric hospital bed capacity of Sinai and another LifeBridge hospital to replace the psychiatric hospital services provided at Grace. This project proposes to reconfigure the Grace Medical Center campus in 2 phases. In phase 1, renovation of an existing 1990s building adjacent to an existing parking garage will create space for the FMF operations. It will have 27 total treatment spaces for emergency services, including 4 behavioral health rooms and 9 observation bays. The campus will also include a number of outpatient services that HSCRC has approved for rate regulation, including imaging, dialysis services, intensive outpatient behavioral health and substance use treatment, and outpatient surgery. In the second phase, existing building space will be demolished and new building space for outpatient behavioral health services will be constructed. The estimated cost of the project is $61.6 million. This will be financed through borrowing in cash, with $50 million raised through bonds and the remainder of $11.6 million funded in cash. Staff is recommending approval of this conversion based on the following key points. The state EMS board determined that adequate and appropriate delivery of emergency care within the statewide emergency medical services system can be maintained if Grace is converted to an FMF. The project is consistent with the state health plan. While slightly larger in treatment capacity than the American College of Emergency Physician Planning and Design guidelines for hospital emergency departments would indicate, based on the projected visit volume, a sufficient basis for the design based on the particular characteristics of the population to be served was demonstrated. The proposed number of observation beds is justified based on the historical current projected use. The project will support more efficient and effective delivery of health services. The hospital being converted has been chronically underused and losing money from operations in recent years. Its physical facilities have needed modernization, requiring a larger expenditure than the proposed conversion. replacing Grace with an FMF-centered outpatient campus can allow the campus to serve as an access point for services needed by an underserved community, increasing the efficiency of providing these services. And these factors all support the finding that the proposed project is in the public interest. In conclusion, staff recommends that the commission approve this exemption from CON review for the conversion of Grace Medical Center to a freestanding medical facility. Among the LifeBridge representatives on the call are Rebecca Altman, Chief Integration Officer at LifeBridge and Vice President of Operations at Sinai and Grace, Jason Weiner, Senior Vice President and General Counsel, Michael Myers, Vice President of Regulatory Reporting and Reimbursement, and Neil Meltzer, President and Chief Executive Officer of LifeBridge Health. Thank you. I will be happy to address any questions you have before taking action on this exemption request.
Thank you, Eric.
Mr. Chairman. I'm sorry if I could just impose upon you for a moment. My name is Daniel Blum. I'm president of Sinai Hospital and Grace Medical Center, and I just want the record to reflect I'm sitting in on behalf of Mr. Meltzer, who is unable to be here today. Just wanted to get that straight for you.
Welcome, Daniel.
Thank you, sir.
Do I have a motion to approve the exemption from CON review for the conversion of Grace Medical Center to a freestanding medical facility?
Commissioner Dordan,
Commissioner
so
Dordan.
moved. So moved.
Second. Commissioner Dordan, second.
Boyle,
Second.
Who was the second? I'm sorry.
Commissioner Boyle.
Commissioner Boyle with a second. Thank you. Do I have any questions or comments? Commissioner
Yes.
Boyle.
This is Commissioner Bhandari.
Commissioner Boyer.
So,
Commissioner Boyer, you were first.
Yeah, Dr. Pollack. So I have a significant concern with this. And my concern is based off of the fact that we are currently still under the conditions of a pandemic, and we are, as a body, are making a recommendation to close a medical facility. I know that this came up before in regards to Havre de Grace and the University of Maryland Hospital. And I couldn't speak up, but I have significant concerns with this. When I went to the MEMS report, I noticed that this particular hospital has been on alert status in the past 6 months 132 times, including once in red, 36 reroutes, and 95 yellow. I recognize that we are currently in pandemic conditions, but I believe based on that, we're in need of these beds, and we're in need of this hospital until the pandemic conditions resolve. I would like to, for us to seriously consider holding off on this until the state designates that the pandemic is over, or at least the conditions that we are doing, making major changes to our society are put on hold and we get back to normal again. I just think that the conditions that we are currently under are not, it's just not a smart thing for us to do, to get rid of hospital beds, take them off the system when we already have very clear evidence that the system is in peril. Thank you.
Just for clarification, none of those beds are open right now. Is that correct?
What do you
Mr.
mean?
Blum, I'll let you answer that.
Yeah, the inpatient beds are not open. The emergency department has been completely redone and is open. And in fact, we have observation beds there. We're also able to accommodate transfers of any inpatient cases to our other LifeBridge facilities or any of the other neighboring hospitals. We work collaboratively with them as well.
Got it. And Mr. Blum, just to be clear, right now, the bed capacity, any bed capacity issues you have, are they related to beds that are open or are they related to staffing?
Thank you for that question. I would say really it's a staffing issue. And I think, you know, all of the hospitals are realizing that issue. I also believe that our color status, alert, yellow, red, is frankly no different from all of the other hospitals, although I respect Commissioner Boyer's comments and I take them seriously.
Thank you. Commissioner Bandari.
So I have an observation, there are so many hospitals in Baltimore area. I think, more hospitals in Baltimore than probably in DC also. Is there a still need for freestanding medical facility?
So I appreciate that question. That work has been done by the HSCRC in conjunction with multiple of the hospital systems in West Baltimore now for some time. So you're asking the question as to whether or not there's even need for the freestanding medical facility. Eric, do you want to take that question?
Well, I think as you alluded to, I mean, that this commission, in the past has worked with HSCRC and LifeBridge to develop what would be the best solution to serving the population of West Baltimore, which has, a high need for service. And the determination was made, and, HSCRC has agreed to, as they showed in their exhibit, it was exhibit 2 in the attachment, that to regulate some of these services. And I think everyone has come to the conclusion that, maintaining a site at this location would be of most benefit to the citizens of West Baltimore, and to close the facility entirely would not be beneficial to the healthcare that's delivered within West Baltimore and within the city of Baltimore.
And Mr. Pollack, if I may, a bit of experiential commentary. In terms of the need for the facility, we find that utilization remains consistent and in fact is strong for our emergency services. I think the experience of the former Bon Secours was that the inpatient capacity was very hard to maintain, and that's what caused financial distress. There is still consistent need for urgent and emergent care in the neighborhood. There's a population of patients who are deserving of care. There are other facilities that are proximate, but utilization for our facility remains strong. And so what we've done really is we've kind of reconfigured a bit to provide the services that we believe the community needs: ambulatory care, diagnostic and treatment services, emergency care, and things like critical care, where we really could not sustain a financially sustainable and high quality service with things like critical care. Those are the items that have been rationalized to the neighborhood facilities.
Thank
Commissioner
you.
Pollack, Commissioner Pollack, this is Commissioner O'Connor. A couple of questions.
Yep.
It seems rather radical for an institution that has 71 licensed beds to go to a freestanding medical facility without considering dropping the number of beds, et cetera, like most other hospitals do. I don't quite understand that. That's pretty radical. Number two is, has there been a public meeting that is mandated by the statutes? And also, the mother hospital, Sinai, is 5 miles away. 5 miles distance in a city, to me, is, I think it does require some kind of acute service facility there. 5 miles in a city is pretty far. And also that 5 miles, that's the upper limit of the criteria for a freestanding medical facility. I mean, is it 5 miles? Is it 5.2 miles? I mean, it just sounds pretty suspicious that it's the mother hospital. The mothership is 5 miles away, which by requisite is a requirement within 5 miles. Also, in the text of this document here, initially it says there'll be certain surgeries, does not include general surgery, but in the EMS report, it mentions general outpatient surgeries. I'm a little confused because within the paragraph, it says, at this time, no additional services are planned to be added. And it only includes ophthalmic, orthopedic, endoscopic, and vascular surgical services. And at this time, no additional services are planned. So I'm a little confused. Will there be general surgery or not at this facility?
So I'll take those two questions separately. So for the first question, I just want to be clear for all the commissioners, that 71 bed capacity hasn't been in place at that facility in as far as in my recollection since I've in the past 20 years. But as I recall, in the past year, I think there have been 6 discharges from Grace total.
That's correct. That's correct.
So we're not talking about taking a facility from 71 to 0. We're taking a facility that's already made the switch with the oversight of the HSCRC in this body to essentially 0 and allowing it to build the new FMF that's been planned. Any other comments on that, Mr. Bloom?
No, sir.
Well, the description of the hospitals claims it's a 71 licensed bed facility at 2000 West Baltimore Street.
Yeah, that's not, that's not.
Page 2. That's page 2 of the handout we got.
Eric, do you want to comment on that?
Eric, you have to comment.
That's the license capacity is managed by the Office of, Healthcare Quality, but as everyone knows, I mean, what's showing on the licensure stats versus what the hospital is actually operating are 2 different factors.
And I'd just like to interject this main point here, which is the Healthcare Commission does provide average daily census to OHCQ. And as a result of that average daily census, the OHCQ modifies the license. However, in the last 2 years, as a result of the fact that we were in the midst of the pandemic, we opted not to enforce those that provision, or actually the secretary asked us not to, not because of any concern at Grace, but because of the implications system-wide. So that 71 bed license capacity actually reflects utilization from several years ago, not what was seen in 2020, and certainly not what is seen today. So Eric is correct in referencing that, but we would typically update license capacity. We have not done that for 2 years.
Thank you. And then Dr. O'Connor, your second question about the nature of the surgery to be performed in those 2 outpatient operating rooms. Mr.
Yes.
Do you want to address that, or one of your team?
Sure. So we actually built 2 brand new general operating rooms that can be used for a variety of subspecialties, as well as a new central sterile processing area. And we look to provide a variety of different ambulatory surgical procedures based on the needs of the community. One of the things that's been very heartening to see is our medical staff, including the chairs of the departments themselves, in OBGYN, orthopedics, general surgery, et cetera, all looking to fill whatever needs the community has. And so we will scale our services over time based on the needs of the community. We have ambulatory practices at the site as well. So patients can receive needed ambulatory preventative follow-up care, pre-surgical and post-surgical, all in the same place. For anything that requires more complex surgery, referral is made to either one of our facilities or a neighboring facility that the patient might already have a relationship with. So there's good continuity of care.
How about a public meeting? Was that public meeting, did that occur already?
Yes, I believe so. And I'd invite Rebecca Altman, my colleague, to speak to that. But even during the pandemic, although we were forced to use some non-traditional means, such as what we're doing today. We have made significant inroads in soliciting feedback from the community, providing our plans around the services that we're hoping to provide, that we are providing. And again, soliciting from the community itself what they want to see with their neighborhood healthcare provider, from their neighborhood healthcare provider.
Hi, good afternoon. This is Rebecca Altman. Yes, we actually held 2 electronic town hall meetings. Because of the nature of the pandemic, we could not hold publicly held town hall meetings. We were granted the permission to hold at least 1. We wanted to hold 2 to make sure that the community had active involvement. And on both of those calls, we had over 100 in attendance. So been working with the community for a number of years now.
Among our other services, there are programs on mental health, drug addiction, methadone maintenance. So there's a broad array of programs that we're offering. We also have observation beds, as noted. We just don't have extended stay acute care.
Commissioner Cheatham, just a quick question with regards to
Commissioner Cheatham, before you move on, I just want to make sure Dr. O'Connor's questions are completed. Jerry, did you have anything else?
Just one more thing. We can expect a rebound in significant cancer surgeries with the delay from COVID and so forth. I just hope we all consider that possibility, and eliminating these beds in these main ORs maybe something to consider.
Yeah, I don't think that Mr. Bloom, if you could just comment. I don't think we've been doing cancer surgery at Bon Secours or Grace for many years now.
That's correct. Unfortunately, there were a variety of subspecialties that over the years had fallen to the wayside. And so we're actually looking to repatriate some of the subspecialties, including oncology, community-based oncology. Again, any of the very complex oncologic surgery would be done in more of an academic environment, and any ambulatory procedures that needed to occur would occur there on site.
Thank you.
I just, for the commissioners who maybe aren't as familiar with this neighborhood, Bon Secours was closing. It was going to be shut down completely. This is an attempt to preserve something for that community that otherwise wouldn't have been in place, and to preserve emergency access in that community, as well as enhanced outpatient access relative to what was there previously. So unfortunately, the concept of having a full service hospital there is not one that has been a reality for some time now, but the LifeBridge efforts here are in fact allowing a piece of capacity and a piece of access to care to continue in a very underserved community that otherwise would have essentially nothing. Dr. Cheatham.
Hi, just a quick question with regards to the public event, the electronic public event that you had attendance. I just wanted to know what the community, how they felt about this change.
Sure, I'm happy to speak to that. So during those public events, they were actually very positive. They were very happy that there would still be access to healthcare. They themselves recognized, many community members, that they would prefer not to have inpatient. And in fact, many, when they needed more critical surgery or more complex care, would actually choose other sites such as Sinai or University of Maryland, so on and so forth. So for them, they thought this was a very positive change. We listened to them. They asked for pediatrics and women's services, which we included right away post-acquisition in the clinic space. So we have been listening heavily to the community. They've been a lot of our inspiration and input. But the reactions during those meetings were all very, very positive.
Mr. Chairman, I have a quick question.
Sorry, I was on mute. Yes, please, Dr. Akinfati.
All right, thank you. And just with respect to all the previous questions and concerns, my question is from an academic perspective. So our biggest rate limiting step for being able to either increase cohort sizes or improve upon the student learning experience for health services programs for different universities here in Maryland is the availability of clinical sites. Has there been any conversation about how this FMF would be able to support that?
Yes, in fact, currently our emergency physicians do have residents and students come through the emergency department there currently today. So it is being leveraged as a site, not just for nursing, but also for physicians as well, as a place for emergency medicine. Absolutely. We are looking to, as we are transitioning, even in our outpatient clinics, welcome students within primary care and the specialty care clinics as well.
We also have 7 residency programs based at Sinai and are looking to increase our participation and profile in medical education at the medical student level. We believe that this is a very important location as our best foot forward from a healthcare equity standpoint, preventative care. And so this will be an important location for us going into the future for that academic purpose.
Thank you. I think that's an important point, and thank you, Commissioner Acontado. That's a very important question. I think Commissioner Acontada's point specifically related to nursing education, though, and I didn't hear a specific answer with regard to whether or not nursing students are rotating through that site.
Commissioner Pollack, this is Rebecca Altman. Yes, they are. We currently have nursing students from various nursing programs around the city who participate in the ED. For us, not only is it an opportunity to train the next batch of nurses, but it's also a recruitment and retention strategy. So many of those nurses actually are sticking around, and once they graduate, we hire them and they know they have a spot to come prior to graduation and getting the board. So we're using nurse externs, nurse grads, and nursing students. So yes.
Thank you very much for that. As a professor in the School of Medicine, obviously, the training of physicians is important to me, but as I've said now 3 times on this call, the rate limiting step to healthcare in this state right now and across the country is access to nurses. So that nursing education has to take a front seat to everything that we do right now. Commissioner Jensen, you had a question.
Yes, just very quickly for Ms. Altman, you had these public hearings and you had them electronically. I'm just curious, because I'm very familiar with that area and that neighborhood, what efforts were made to make sure that the people that attended those electronic meetings were representative of the people that live in that area?
Actually, thank you. That's a very good question. So what we actually did was use a different modality that combined electronic also with the phone services. So we worked with and partnered with a company that many of the delegates and senators located in West Baltimore who represent their constituents utilized for their town halls during the pandemic. And so it was phone calls specifically to the residents that live in that zip code. And so we could see who would join from what area based upon the zip codes that we gave them to really project and be able to handle the folks that would join us. So we targeted a targeted approach for the West Baltimore residents.
We recognize that not everybody had a smartphone or an internet connection in their residence. And in addition, what we realized was that we needed an alternate means to make people even aware that we were going to have these forums. So there were paper flyers, certain areas were that were found to be gathering points, like laundromats, for instance, were identified as locations where we could make people aware that these meetings were going to occur because we anticipated that we would benefit from robust participation. The last thing that we want to do is alienate the community or make errors.
Thank you.
Thank you. Any additional questions, commissioners? I have a motion and a second on the floor. All in favor of the motion to approve the exemption from CON review for the conversion of Grace Medical Center to a freestanding medical facility signify by saying aye.
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 Great. Opposed?
Opposed?
Commissioner Boyer, anybody else? Very good. The vote will reflect all, one opposed. I hear background noise now. I just want to make sure that that background noise isn't another commissioner with a clarification of a vote. Okay.
O'Connor, opposed.
O'Connor opposed. Okay. Commissioners Boyer and O'Connor opposed, all others in favor. The exemption from CON review for the conversion of Grace Medical Center to a freestanding medical facility is hereby approved. Thank you to the team from Sinai and LifeBridge.
Thank you.
All right, on to agenda item number 5, percutaneous coronary intervention services, Suburban Hospital. The next agenda item is for consideration of an application for a certificate of ongoing performance for PCI services for Suburban Hospital, which provides both primary and elective PCI services. Staff will discuss the state health plan standards that apply to the application, and then there will be a separate brief discussion and vote on the application. Marianne Dogo Isanagi, Program Manager, will present the report for Suburban Hospital. Marianne, please proceed.
Thank you, Mr. Chairman, and good afternoon, Commissioners. A summary of the standards for a certificate of ongoing performance for PCI services that have been established by the Commission is shown in the slide. Next slide, please. The hospital has met the requirement that primary PCI services be available 24 hours per day, 7 days per week, with 2 exceptions during the review period due to unavoidable circumstances, specifically an electric power transfer to a newly constructed control center. With respect to the door to balloon time standards on a rolling 8-quarter basis, the hospital complied with the standard in the 10 most recent periods, but not the 6 periods ending between 2017 quarter 1 and 2018 quarter 2. The hospital provided explanations for the door to balloon times greater than 90 minutes in all quarters prior to 2019 and the corrective measures taken. Although data is provided in the report through calendar year 2020, but of note, the standard has been waived for calendar years 2020 through 2021 due to the COVID-19 pandemic. For risk-adjusted mortality rates for the rolling 12-month periods, as shown in the 6 applicable reporting periods listed, the hospital is performing similarly to the national benchmark for STEMI and non-STEMI cases. The hospital also met the benchmark for all earlier reporting periods going back to calendar year 2015, but again, the standard only became effective January 2019. The program also performed over the target volume of 200 cases annually. Program volume ranged from 403 to 490 cases annually between fiscal years 2015 and 2019. The volume of primary PCI cases ranged from 89 to 96 cases annually for calendar years 2015 through 2019, which is greater than the 49 cases required annually. Next slide, please. Between 9.6 and 20.7 elective cases went through external review per calendar year, exceeding the 5% required, and the frequency of review was semi-annually from 2016 through 2019. Semi-annual external reviews for each individual interventionalist were met through a combination of external and internal review. The next standard pertains to a requirement that a hospital holds multiple care area group meetings monthly that includes physician, nurse, and leadership of each care area who care for primary PCI patients. We learned that during the review period, the hospital has often held meetings less often than required and attendance has not been documented. Because meetings occurred infrequently and attendance was not being consistently tracked, we are recommending that a condition be included on the certificate of ongoing performance for the hospital with formal follow-up by the commission. No primary cases were identified as inappropriate during the review period, and MHCC staff requested additional information on elective cases identified as rarely appropriate by the external review appropriateness criteria. The hospital provided information about the follow-up on these cases and reported that no trends were identified. Staff recommends that the commission find that the hospital has complied with all standards and approve the certificate of ongoing performance to allow Suburban Hospital to continue providing primary and elective PCI services for the next 4 years, with the condition that Suburban holds monthly multiple care area group meetings as required in COMAR and shall submit to the commission staff attendance list for each of these meetings held between January and June by August 1st of each year, and attendance list for meetings held between July and December by February 1st of each year until at least February 1st, 2023. After this date, the executive director may release Suburban from the reporting requirement if the executive director determines that the hospital has achieved substantial compliance with this condition. We have hospital representatives Becky Kane, who's the director of cardiac cath lab, Eileen Poomer, who's the senior director of quality, patient safety and improvement, and Mary Maloney, who's the cardiovascular data manager, and Diane Hollenberg, who's the cardiovascular data abstractor, all on the line, who can respond to questions or provide additional information on their PCI program as needed. Thank you.
Thank you, Mary Ann. I'll entertain a motion to approve the proposed certificate of ongoing performance.
So moved, O'Connor.
A second,
Cheatham.
Commissioner Cheatham with the second. Thank you. Any questions or concerns? Just a quick question, Mary Ann. The condition that we added is very similar to one that we've added for I would say the majority of other hospitals that have gone through this process now. Is that accurate?
Yes, it is.
Any other questions or concerns for Mary Ann? Hearing none. All in favor of approval of the percutaneous coronary intervention services Suburban Hospital certificate of ongoing performance?
Aye.
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 Any opposed? All right. Thank you. The certificate of ongoing performance for PCI services for Suburban is hereby approved. On to agenda item number 5B, cardiac surgery services at Suburban Hospital. The next agenda item is the consideration of Suburban Hospital's application for a certificate of ongoing performance for its cardiac surgery services. Jessica Raisman, Program Manager, will present a brief overview of the state health plan standards that apply and then the report for the hospital. Jessica, please proceed.
Good afternoon, Commissioners. This staff report evaluates Suburban Hospital's compliance with standards related to cardiac surgery services. Next slide, please. A summary of the cardiac surgery service standards that have been established by the Commission are shown here. The standards relate to data collection, quality, performance, and volume. Next slide. On this slide, I've highlighted some of the standards that were reviewed for this certificate of ongoing performance application. Standard 7B4B requires that the hospital demonstrate that it's taken appropriate action in response to concerns identified through its quality assurance practices. Suburban submitted a list of meeting dates and documentation from 2015 to 2020 for 3 different committees related to cardiac surgery quality assurance. Suburban also submitted a summary of recommendations from and the actions following up on an external review that was initiated by the hospital. Staff determined that Suburban took appropriate action in response to concerns identified through the internal and external review processes. Standard 7B5A states that the hospital shall maintain an STS composite score for CABG of 2 stars or higher. If the composite score for CABG from STS is 1 star for 2 consecutive cycles, the program will be subject to a focused review. And if the composite score for CABG from STS is 1 star for 4 consecutive rating cycles, the hospital's cardiac surgery program will be evaluated for closure. However, Suburban has maintained an STS composite score for CABG surgeries of 2 stars or higher for each of the 12 overlapping 12-month periods between July 2014 and December 2020. The next standard 7B5B states that the hospital shall maintain a risk-adjusted mortality rate that's consistent with high-quality patient care. A hospital with an all-cause 30-day risk-adjusted mortality rate for a specific type of cardiac surgery, such as CABG cases, that exceeds the national average beyond the acceptable margin of error calculated for the hospital by the commission is subject to a focused review. The current standard, which references a national average, was adopted in January 2019. Prior to this time, the standard referenced a statewide average, but both the national and statewide average for all time periods between July 2014 and December 2020 are presented in Table 2 of the staff report, which is found on page 10. While the program complied for 9 of the 10 reporting periods, because the hospital performed statistically significantly worse than the statewide average for the period of July 2016 to June 2017, MHCC arranged a focused review of the cases with mortality. The external review organization found that the program had implemented appropriate measures to improve outcomes. Additionally, the risk-adjusted mortality rates have improved, and the program has met the standard in every subsequent review period. Standard 7B6 states that cardiac surgery program shall maintain an annual volume of 200 or more cases. However, the standard goes on to say that it's acceptable for a program to perform less than 200 cases as long as it demonstrates the provision of high quality care. The state health plan states that if the cardiac surgery program fails to reach an annual volume of 100 cardiac surgery cases for 2 consecutive years, the program will be subject to a focused review. Based on staff analyses, Suburban did not meet the requirement that it maintained an annual volume of 200 cases or more in fiscal years 2016, 17, 18, or 19. However, it performed 194, 169, 199, and 180 cases during these years, respectively. As you can see, the hospital's volume was well above that 100 case mark. So staff's review of mortality rates, STS star ratings, and the results of the focus review suggest that the program does provide quality care and is committed to quality improvement. Next slide, please. Staff recommends that the commission find that the hospitals complied with all standards and approve a certificate of ongoing performance to allow Suburban Hospital to continue providing cardiac surgery services for 4 years. Suburban Hospital must continue to comply with Condition 3 of its Certificate of Need for the Cardiac Surgery Program, which requires submission of an annual report that includes an evaluation of the effectiveness of the hospital's proposed regional outreach efforts related to cardiovascular disease prevention and early diagnosis. As Mary Ann mentioned for Suburban in the last report, we have hospital representatives on the line. We have Eileen Pummer, the Senior Director of Quality Patient Safety and Improvement, Diane Hollenbeck, a cardiovascular data abstractor, and Mary Maloney, the cardiovascular data manager, all on the line who can respond to questions I cannot answer. Thank you.
Thank you, Jessica. Do I have a motion to approve the certificate of ongoing performance for cardiac surgery services at Suburban Hospital?
I so move.
Commissioner Akintada, do I have a second?
Commissioner Boyle,
Commissioner Boyle, second. She beat you, Commissioner Cheatham. I saw the mute come off. Any questions or concerns? Hearing none. Great presentation, Jessica. All in favor?
Aye.
Aye. Aye.
Any opposed?
Aye.
Just want to make sure none of those was an opposed. Any opposed? Very good. Hearing none. The certificate of ongoing performance for cardiac surgery services at Suburban Hospital is hereby approved. On to agenda item number 6, position on regulatory oversight of hospital at home programs by the Maryland Healthcare Commission. Earlier this year, a joint chairman's report directed HSCRC and MHCC to develop a report on creating a hospital-at-home model of hospital care available in Maryland. The JCR asked the agencies to consider potential barriers in the existing state law and regulations that currently exist to prevent the broadening of this model. Paul Parker, Director of Healthcare Facilities Planning and Development, will present a recommendation on the question of whether MHCC has regulatory oversight responsibilities for any aspect of a hospital-at-home model established by a Maryland hospital. Paul, please proceed.
Thank you, Chairman Pollock, members of the commission. Because the JCR report specifically asked for identification of any barriers in existing state law and regulation that currently exist to prevent the broadening of the hospital-at-home model, I wanted to be sure to get the commission's position on that particular issue that needs to be addressed in this report. HSCRC is taking the lead on developing of this report. One of the background pieces that you were sent is a short slide deck that provides background on what a hospital-at-home program looks like. They're in the process of finishing their drafting of the report. And my recommendation, the staff's recommendation, is that we respond to the JCR that MHCC's regulatory oversight of hospital services is not a barrier to broadening this use of this model in Maryland. Just a couple of brief points. When we look at the scope of certificate of need regulation, I think there's two areas that need to be noted here. The scope of certificate of need regulation does include regulation of the supply of hospital beds. So changes in hospital bed capacity, generally speaking, require a certificate of need. Obviously, a hospital-at-home program has the effect of allowing a hospital to broaden its available bed capacity in the sense that that patients who would otherwise be admitted to a hospital bed would be returning to their home and receiving hospital care in that home setting. So it allows a fluctuation in effective bed capacity on a day-to-day basis of an undetermined size, depending on how much this model is used. But in our view, this is really not anything like what is envisioned in the law as far as regulatory oversight by the commission. We are a regulatory body that considers the need for capital investment by hospitals, and this is not a program that would be analogous to that in any way. And in fact, to the extent that this sort of model is successful in Maryland in actually diverting patients away from the hospital, it actually will reduce demand for hospital bed capacity as it is conventionally understood, which is beds and patient rooms that are located in the institutional setting of a hospital. There is one aspect of the scope of CON regulation that is, I guess in a technical sense, a hypothetical possibility here. Hospitals who make a capital expenditure of $50 million, the lesser of $50 million, or 25% of their annual budgeted revenue under HSCRC's current payment model, require a CON. And this is not categorical. So if it's a capital project for any purpose that reaches those expenditure thresholds, it requires a CON. So it is, I guess, hypothetically possible that there could be a big capital project proposed by a hospital whose primary purpose is to make it possible to implement a hospital-at-home program. But we consider this such an inconceivable possibility that we don't think that we should say that this actually represents a real or practical barrier to broadening the hospital-at-home model in Maryland, since it's just not something that's ever going to happen. This clearly is a a type of program that can be implemented without any sort of capital investment. So for that reason, staff is recommending that we take a position in this report that our regulatory oversight of hospitals does not constitute a barrier to broadening of the hospital at home model. And I'm just seeking your affirmation of that recommendation.
So before we, let me go ahead and I'll take a motion to adopt the position on regulatory oversight of hospital at home programs by the Maryland Healthcare Commission.
Moved.
Commissioner Boyer, second. Is there a second?
Commissioner Cheatham.
Commissioner Cheatham, there we go. All right, I was afraid people had fallen asleep on me. And before I begin conversation on this, I just want to remind commissioners that the question before us is whether or not there is an impediment to hospital home in the existing regulatory authority or regulatory infrastructure of the commission. This is not, today's not the time for a broader discussion of the value of hospital at home, of the payment models that would apply in the context of hospital at home, how that would be managed under GBR. All of that requires very broad discussion and involvement of the HSCRC, and it's all very relevant and important. That's not the question that's in front of us at the moment. If I'm correct, Paul, the question that's in front of us is, do we have a regulatory barrier that exists that needs to be addressed if this model is to be considered? Is that correct?
That's correct. And you will have an opportunity to look at the final report when that is ready for your review later this year.
Got it. So we have a motion and a second. Do I have any questions or any concerns to be raised?
This is Marcia.
Yes, Marcia.
I know this isn't pertaining to the question on the table. I realize that, but I'm curious as to who has authority to ensure quality of patient care.
I would say that is the Maryland Department of Health, and specifically the Health Facilities Licensing Unit, which is the Office of Healthcare Quality.
So we have absolutely nothing to do with that.
We obviously have an important role in coordinating and collaborating in our regulatory oversight of hospitals with the licensure folks, depending on what type of project and what sort of change is being proposed. The Office of Healthcare Quality is also being consulted in this report, and so it is up to them to weigh in on what sort of issues expansion of a hospital at home program would raise for their oversight of quality and patient safety, which are their primary objectives.
Thank you.
I had I said sort of a question, comment. I think Chair Pollack's comment is well taken. I don't want to talk about the how, but I would like to see some recognition, I guess, in our report that hospital home will drive down costs. And I think it would be appropriate for it to ask the HSCRC to specifically address how do we realize those cost savings, we, the state of Maryland, and the payers and the members and all those things realize that cost savings. It seems like we could have some acknowledgement that that is something before the HSCRC, and we'd like to ask them to address that.
I think we can assure you that comment will be forwarded to the HSCRC staff who are actually drafting this report.
But and just to close out on my comment, I like our position. I think it's the appropriate position for us, the MHCC, to take. Thank you, Paul.
This is Commissioner Bhandari.
Commissioner Bhandari, go ahead. Yes.
How they will decide which patient need to be taken care at hospital at home program? Is there going to be criteria? How are they going to pick and choose?
That's going to be part of the major discussion that has to occur around what this program looks like.
I think that's correct. Yes.
All right. So I have a motion and a second to adopt the position on regulatory oversight of hospital at home programs by the MHCC. All in favor?
Aye.
Aye.
Aye. Aye.
Any opposed?
Aye.
No matter how long I wait to ask that second question, it's never long enough. Any opposed? Very good. The position on regulatory oversight of hospital at home programs by the MHCC is hereby adopted. On to agenda item number 7, presentation on advanced care planning, a multi-lens analysis. This last agenda item is a presentation on advanced care planning. In summer 2021, the commission conducted an analysis of Medicare data to explore advanced care planning use in Maryland. Shade Paul, Program Manager for Government Relations and Special Projects, will present the findings. Shade, the floor is yours.
Thank you, Chair Pollak. Can everyone hear me?
Loud and clear.
Wonderful. Good afternoon, everyone. I hope you're doing well. My name is Shade Paul, and I will be presenting findings from an analysis conducted by the Commission. Next slide, please. The topic of today's presentation is Advanced Care Planning, a First Look. Next slide, please. This presentation will include 4 sections: background on the project, our key findings, recommendations based on our findings, and a conclusion. Next slide, please. The foundation of this project was 2 publications that assessed advanced care planning. The first is titled, "Despite Big Buildup, Few Benefit from Medicare's Advanced Care Planning." This article was published in 2021 in the Journal of the American Medical Association, or JAMA. This article provided an overview of the advanced care planning benefit, an explanation of coverage, and a summary of barriers that prevent high provider uptake. The second is titled Advanced Care Planning for Medicare Beneficiaries Increased Substantially, but Prevalence Remained Low. This quantitative study, published in the journal Health Affairs in 2021, assessed advanced care planning use over time, where billed services were provided in the clinical setting, and demographic characteristics of patients across all types of visits. This study was used as the methodological model for our analysis. These 2 studies led us to ask, how is advanced care planning used in Maryland? As a result, in summer 2021, the Maryland Healthcare Commission began a project to explore advanced care planning, or ACP, in Maryland. We conducted a quantitative analysis of Medicare data from 2016 to 2020 to determine ACP use across 4 demographic categories: race, gender, age, and geographic location. Deliverables for this project was a presentation at the Advanced Directives Workgroup meeting in September, a presentation at today's commission meeting, and a data infographic. Next slide, please. So, what did we find? Next slide, please. Overall, beneficiaries with advanced care planning claims increased from 2016 to 2019, with the biggest increase from 2016 to 2017. During the pandemic in 2020, beneficiaries with advanced care planning claims decreased by 7% compared to the previous year. Next slide, please. To better understand ACP use across demographic characteristics, we assessed beneficiaries with advanced care planning claims by race, gender, age, and geographic location. We analyzed beneficiaries across 5 race groups: Asian, Black, Hispanic, White, and Native American or other. What we found was as we expected. As seen in the red portion of the pie chart on the right, White patients accounted for 67.3% of the claims, which was the largest proportion of the claims. Black patients followed with 26%, as seen in the dark blue portion of the pie chart. Asian patients, Native American or other patients, and Hispanic patients combined accounted for less than 6.7 claims. Next slide, please. In 2020, the rate of beneficiaries with ACP claims per 1,000 was relatively even among all race groups. However, white patients had the highest rate of claims. Hispanic and Native American or other had the lowest rate of claims. But it is important to bear in mind that these two race groups account for the smallest proportion of overall beneficiaries with ACP claims. Next slide, please. We assessed beneficiaries with ACP claims over time. From 2016 to 2020, ACP claims among white patients and Black patients steadily increased and peaked in 2019, before the COVID-19 pandemic. As evidenced in the graph on the right, white patient claims increased by 79%, and Black patient claims increased by 70% from 2018 to 2019. However, from 2019 to 2020, white patient claims decreased by 4.3%, and Black patient claims decreased by 11.5%. During the pandemic in 2020, white patients had 40% more ACP claims than Black patients. Next slide, please. We examined claims by gender. As expected, women had more claims than men. But when we looked at claims by gender and race, we found that white women had twice the number of ACP claims than Black women, and the same pattern existed for males. We found that Hispanic men had the lowest rate of claims across all race categories. However, as mentioned previously, this race group is a small proportion of the overall visits. Next slide, please. We assessed claims by age from 2016 to 2020. Overall, what we found was beneficiaries with ACP claims per 1,000 declined by 10% during the pandemic among patients age 65 and over. Next slide, please. Finally, we assessed ACP use in each of the counties in Maryland. During the pandemic, ACP use per 1,000 was higher in 2020 than in 2019 in 8 counties: Caroline, Carroll, Cecil, Garrett, Howard, Kent, Queen Anne's, and Somerset counties. Among the 5 largest jurisdictions, Anne Arundel and PG counties had the lowest rates. From 2019 to 2020, St. Mary's County, Charles County, and Baltimore City had the biggest declines. Overall, Garrett County had the lowest rate each of the 5 years. Next slide, please. So, how did our findings compare to the results in the Health Affairs study? Both analyses found that people younger than 65 years had lower use. However, the Health Affairs study found higher use among patients who either had a terminal illness or were at risk of dying the following year. As expected, both analyses found that women had more ACP visits than men. Finally, both analyses found high claims in white and Black patient claims and lower use between Black and Hispanic patients. Next slide, please. To more accurately frame our findings, it is important to note the limitations in the Health Affairs study and our analysis. Neither study included qualitative data. It would be interesting to do a follow-up study to assess knowledge and perceptions of advanced care planning to identify barriers and facilitators of use. The health affairs study was conducted before the COVID-19 pandemic in 2020, so data from this year was not included in their results. Our analysis had multiple limitations. We did not consider the effect of socioeconomic status on race, gender, and geographic location. We did not assess confounding variables and how they could have impacted our findings. We also did not look at specific diagnosed conditions like cancer and hypertension, which could provide a deeper understanding of ACP use. We did not look at claims by site to determine whether ACP use whether ACP was used during or apart from a wellness visit. And finally, we did not look at the timing of ACP, whether it was at the time of death or a year before death. Although our analysis had these limitations, there is opportunity to examine these variables in a future analysis. Next slide, please. Lastly, I will present our recommendations and conclusion. Next slide, please. Based on our findings, we identified 3 recommendations. First, there is a need to develop targeted campaigns to increase knowledge and awareness among underutilized groups. Second, pilot programs can be designed and launched not only to promote patient-provider communication, but also to increase use of advanced care planning. Finally, there is a need to identify factors that explain differences in advanced care planning among select low-use populations. Next slide, please. In conclusion, advanced care planning is important for informing medical decision-making. Results from this analysis provided confirmatory evidence that advanced care planning, even though available, is underused. And medical and public policy interventions may expand use of advanced care planning. Next steps are to plan to do additional analyses, work with the MDPCP program to determine possible impact, and align this work with other end-of-life initiatives. Next slide, please. I would like to thank everyone on this team for their dedication to this project. Ben Steffen, thank you for your leadership and guidance. Tracy DeShields, thank you for your advice. Ken Yates-Trotman, Mahi Nagatu, and Ose Emasialu, thank you for the skills, technical expertise, and hard work that you brought to this project. I would also like to thank Lavon Ward for advancing the slides for this presentation. Thank you, and I am available to answer questions.
Thank you, Shade, for a great presentation on a very, very important topic. Commissioner Jensen, I believe you had a question.
Did. First of all, thank you for that very, very interesting presentation. I was just curious, is there any data out there that correlates ACP planning and the number of people who then go on to get a written medical directive?
That's a great question. Thank you for asking it. So the 2 studies that we used as foundational studies for our analysis, they made a note to state that there is not a lot of research on this topic. However, a part of your question asked about some of the limitations. So one of the things that one of the studies mentioned was that although we are able to capture ACP use in a clinical setting using claims data, ACP conversations could be happening outside of the clinical setting. So some of these conversations people could be having on their own with their families or with an attorney. So it would be interesting to do some type of research to better understand how ACP conversations are happening outside of a clinical setting. But right now, there isn't a lot of research out there on advanced care planning, specifically in using national data or in the state of Maryland. This is why our findings was something that we were excited to present to the commission, And there is potential to do more analyses based on some of the data that we found.
Thank you. Thank you for the answer.
Dr. Pollack, if I could just for a second expand on, so Commissioner Jensen is new to the commission for the last 5 or 6 years, perhaps even longer. We've worked with the Department of Health and CRISP to develop a mechanism through which patients could construct electronic advanced directives. That work has not been completely successful as measured by uptake. In the past session of the legislature, there was additional proposals to expand that effort. We are currently working with a work group of stakeholders, including healthcare providers, payers, stakeholders, AARP and others, to determine if there's a legislative requirement that would be needed to enable information on advanced directives be more readily embedded in various communications, enrollment forms, patient portals that the various organizations, including both providers and payers, use. The idea of pairing it with Medicare claim data is an interesting one, and one that is technically feasible, but one we haven't examined in any detail. I think the key point here that we want to emphasize is that as we are directly involved with that initiative and the Maryland Primary Care Initiative, that there are ways to gather important provider and payer audiences into the importance of these activities.
I did want to follow up Ben's comment. I mean, there is some discussion with payers for this. Nobody wants their insurance company sending them papers that they can sign so that we can avoid paying claims in the event they get really sick. There's a fundamental message disconnect there. And also it's 17%, the insured population is 17% of the luckiest, I guess you could say, because they have insurance coverage and they can afford it, group of folks. It's really not a good solution, even though I keep seeing it come up because people think there's some deep pockets associated with it. It's not an adequate solution.
Other comments? So I think this work has identified some important potential, some important disparities as well that clearly need to be addressed further. And we need to understand how to take this information and turn it into something that is more actionable. As Dr. Thomas would be likely pointing out to us if he were still at the meeting. So thank you.
Thank you.
Up next, Ben, you want to give us an overview of our next meeting?
Yes, as usual, we would expect to have several CON actions before the commission. We actually, I think, are at the conclusion of our certificate of ongoing performance reviews. So there will be none of those, I believe, in November, but CON actions will be on the agenda. As is typical in November, Ken Yates Trotman will bring the payer submission manual for the all payer claims database to the commission. As you recall, last month we offered proposed regulations to change the requirements on data collection. Vice Chair Sargent raised a question about collection of alternative payment model data. I want to assure him that the vehicle for informing payers is through this submission. And for 2022, we have no intention of collecting that information in 2022, although certainly, as he's aware, collection of AAPM information, as it's an important feature of healthcare quality and reimbursement, is is going to be a continuing debate. David Sharp, our leader on the Maryland Primary Care Program, will provide an update on the third track of this model. We are, of course, working closely with state partners at the Department of Health and HSCRC and Maryland Primary Care Program Office to put in place a proposal that will be agreeable to CMMI for continuing the program into 23 through 26. This has been a very important objective of the department as we move towards aligning this program with initiatives in the private sector as well as Medicaid. I expect that we would also have several other updates that we would want to share with the commission. And of course, we'll have our informational retreat on the November 19th. I sent the preliminary information earlier today regarding that event. More will be coming. That's all I have, but we'll happily answer questions.
Any questions for Ben about today's meeting or about the upcoming agenda? I want to offer my deep thanks to the staff for a fantastic job getting us through a busy agenda in record time. And thanks to the commissioners for great preparation for this meeting. And with that, I'll accept the motion to adjourn.
So moved.
Do I have a second?
Second.
Any opposed? Thank you, everybody. Have a wonderful month, and we'll see you next month.
Thanks, everyone.
Ben, this
Thanks, everyone.